This morning we're doing Kimberly-Clark's thoracic radiofrequency ablation procedure at the right side at T8 and T9 at the medial branches. Increasingly, we're finding that more and more patients are coming to our practice with thoracic back pain, particularly patients who have previously had vertebral body augmentation procedures can have persistent mid-back pain that will often respond to this procedure quite well. Again, in order to proceed with this procedure, we do medial branch blocks in the thoracic spine, looking at double-blind comparative blocks with 80% reduction in pain. Again, some practices will use 50% reduction over one block, but that's a practice-to-practice decision. Some of the interesting things about the thoracic spine are that there's variability of the medial branches. And one of the advantages of this procedure is that it accounts for that variability by giving you a bony backstop, increasing safety for the procedure. The other advantage of the procedure is that the distal projection of the lesion allows you to capture the medial branch without having to alter your trajectory or position significantly. So to get started, we're going to do, again, the T8 and T9 medial branches. First, we are going to identify the T8 vertebral body, and then we're going to line up the end plate. And in this position, we've got a fairly reasonable looking end plate. The medial branch of the T8 vertebral body actually exists at the transverse process below that level. Use the superior lateral corner of the transverse process as your target. I'm going to mark it here. For T9, we use the transverse process at T10. And again, we mark the superior lateral corner as our target. Following skin anesthesia, I typically enter the skin just below the superior lateral corner so that I can give myself some leeway in terms of my trajectory. Okay. Once I've entered the skin after skin anesthesia, I advance the needle to bony contact, ensuring that I use the bone as a backstop to my placement. And at this point, I'm going to place my additional needle as well. Again, using a slightly inferior approach so that I can continue to use the bone of the transverse process as a safe bony backstop. Once I've placed the needles and I have bony contact, I move to a lateral view. This view can be used to ensure that you're not too deep and also to confirm appropriate placement. And as you can see here, we're not too far deep and we're right at the level of the transverse processes. At this point, I typically walk my needle up slightly so that I'm, again, remaining on the transverse process, but have gotten into a space that will allow me to capture the medial branch with my lesion. The next step is to remove the stylet and inject with a local anesthetic mixture. I then place the probe at both levels. You want to wait 30 seconds to a minute prior to proceeding with the lesion. And I typically confirm one final position in AP to ensure that, that I'm happy with the positioning of my probes. Once I've confirmed position in AP, I begin the radiofrequency protocol, and using the multi-cooled RF module, I'm able to do 2 to 4 lesions at one time. Once the procedure is completed, I remove the probes and inject a steroid and local anesthetic mixture, and subsequently remove the needles. What you've seen today is thoracic medial branch radiofrequency ablation performed with the Kimberly-Clark Thoracool device that simplifies the procedure while giving you an increased safety margin with a bony backstop and a distal projection of the lesion that captures the medial branch while being placed in a safe and effective and reliable manner. Thank you for watching.